Welcome to webinar number 252 of the Andean Organism of Health in a convention with ROSCOM. It's been 4.5 years and continuous learning since we began this important space for webinars in May of 2020. The current webinar is part of a special cycle of webinars since September of 2024 in a synergic process with Copenhagen Institute for Future Studies. My name is Stephanie Tafur Contreras. I'm a health professional, and I am in charge of moderating this webinar. Today, on November 22nd, we are going to talk about the relevant issue of respiratory diseases, including COPD and respiratory health from the point of view of the patient and their family, the vision on treatment and prevention and stigma reduction associated to this disease, and the attention to chronic respiratory diseases and COPD is on behalf of WHO. The relationship of the Andean Association with this disease is complex, and it is due to socioeconomic factors as well as air pollution. The vehicle emissions, industrial emissions, and solid fuels are some of the main sources of pollution that affect respiratory health, as well as climate variations such as the El Niño phenomenon can affect respiratory health by affecting precipitation, which affects the quality of the air and the propagation of viruses. The pandemic has had a deep impact on respiratory health, although measures have been implemented to control COVID. These also affected the attention that was given to other respiratory diseases. Likewise, there has been an increase in awareness on preventive measures such as use of face masks and frequent hand washing. As a strategy in response to this issue, it is crucial to strengthen the sanitary system, the health system, to improve the health infrastructure and access to quality medical professional. Community education on prevention of respiratory diseases, as well as the implementation of monitoring systems to monitor air quality, can decrease the negative effects on public health. Coordinated between governments, non-governmental organizations, and communities to improve public health and reduce its impact. Thoughts such as these and other relevant priorities can be found in the news bulletin of the Andean Health Community, which is going to be published on the webpage, as well as the Andean Integration Portal, which we invite you to visit. Now we invite you to put your name, organization, and the country that you hail from in the chat, either be it in Zoom, Facebook, or YouTube Live. In this same space, we invite you to leave your questions or send them through email, webinars, or to the Gmail. To solidify your assistance to this webinar, you need to fill out your information through the form and the link that will be provided through Facebook and YouTube Live. And please, we want to remind you to verify that your email is correctly inputted. This webinar is going to have the following dynamic. We will begin with the institutional greeting of CIFS, followed by the presentations, followed by the Q&A. We will now begin this important webinar, and our Executive Secretary of the Andean Organization of Health, Maria del Carmen Calle, is going to give our institutional greeting. Go ahead, Dr. del Calle. Thank you so much, Stephanie. Well, for me, it's a pleasure to be here with all of you. As was mentioned, I am the General Secretary of the Andean Association Politonanwe. Respiratory health is considered an important topic in public health. Regarding respiratory illnesses such as asthma, the obstructive pulmonary disease, COPD, are some of the most important causes of mortality and morbidity in the world, especially vulnerable populations, such as children below the age of 5, as well as elderly people. This represents a significant load on health systems, and it has a considerable impact on the quality of life of the populations. It is estimated that worldwide over 400 million people suffer from asthma and about 300 million suffer from COPD. Respiratory diseases are responsible for about 3.9 million deaths per year, which represents around 7% of all the deaths globally. Likewise, respiratory diseases, chronic respiratory diseases, cause 8.9 million years 8.9 million years of life lost and over 5 million years of life lost due to disability. COPD has had an important impact on respiratory health. There have been increase in cases of pulmonary fibrosis after COVID, as well as the increase in respiratory diseases related hospitalizations. The Orascona promotes the creation of public policies on a sub-regional level to improve the access to health services, which includes a focus on respiratory diseases. This is framed within the strategic integration plan of the Andean Community for Health 2013 to 2017, which establishes common priorities in health and reflects specifically in actions such as the Andean Plan for the Prevention and Control of Non-Transmissible Diseases, Plan for Climate Change 2020-2025, among others. Likewise, we have improved the diagnosis of NCDs in children because there is a high prevalence and incidence on them. During the pandemic, Orascona has been involved in monitoring and response to respiratory diseases, including COVID-19. This way, the comprehensive approach of Orascona towards respiratory diseases includes research, diagnosis, treatment, and emergency response for health emergencies, highlighting its commitment with improving public health in the Andean region. For our organ, the respiratory illnesses such as tuberculosis, pneumonia, COVID-19, among others, are a relevant topic in the institutional agenda, and they are approached in a cross-sectional manner and are also part of interregional policies, projects, and events. And there is constant epidemiological surveillance that's been conducted in the Amazonic and Andean regions. Our sub-region faces significant challenges in public health due to the fragmentation and subfinancing of the health systems. The implementation of comprehensive policies is crucial to deal with these problems and improve the quality of emergency response for the health system. This reflects the urgent need to strengthen preventive measures and the health systems to protect the population that is most vulnerable in the Andean region. In this context, Orascona in a close alliance with the Copenhagen Institute for Future Studies, CIFS, we have invited Dr. Sarah Rylance, who is in charge of PS's management of NCDs, Dr. Tonya Winters from GAPP, member of its directive committee, and Dr. Anders Locke, who is a research and professor in the University of Denmark. We are also going to have comments from Dr. Oscar Galloso Cervantes, a pneumologist from the Cayetano Radio Hospital, and Dr. Laura Nicolau Fernandez, who is a professor in the pneumology and intensive therapy division in the Johns Hopkins University. We thank our presenters and commenters and our alliance with CIFS for contributing to this knowledge regarding respiratory illnesses. Orascono acknowledges this important opportunity to allow visibility for the issues of respiratory health because it affects millions of people in the Andean subregion and in the world. Thank you so much and welcome.
Muchas gracias, querida doctora Calle.
Thank you so much, Dr. Kaye. Now we have the honor of having Dr. Aboshi Eliasen, who is the director of the Copenhagen Institute for Future Studies, who is now going to give his official greeting. Go ahead, doctor. Thank you so much, and thank you for organizing this webinar with us. It is an honor for us to work with ORAS, and this time that we have worked with them, it's been many years, and especially today, this issue with COPD and respiratory health, I am so happy that we can bring this work to the context of the Andean countries where this is also a huge challenge. The basis of this work is a concept that we have worked on for the last few years with respiratory health and the work that we've done with COPD this year that has been launched. We have had many discussions about this, and we have been promoting this information to have alliance and a more global discussion regarding how we can improve this area. Dr. Maria has already made clear why this is a challenge, and with the three speakers that we have, we will see how we can promote visibility of this area. So I am looking forward to these 2 hours of discussion presentation. So thank you so much.
Muchas gracias, doctor Boya.
Thank you so much, Dr. Boy. Now we shall begin the conference, offering a cordial welcome to Dr. Tanya Winders, who is going to give us a dissertation on COPD and respiratory illness from the point of view of patients and family. Tanya Winders is the President and General Director of Global Allergy and Airways Patient Platform.
Pertenece a la iniciativa GART de la
And she's
Organización Mundial de la
part
Salud.
of the GAP initiative of WHO. Go ahead, Dr. Winters.
So again, I'm unable to be on camera, and I thought you all were going to play the video at this point. Is that correct? My video presentation?
Good morning. I'm Tanya Winters, the President and CEO of GAP, the Global Allergy and Airways Patient Platform, and it's my pleasure to be with you today. Sorry that I cannot be live on camera as I'm traveling. My father is actually having some health issues, and I am headed on a 500-mile car ride today, so forgive me for not being there and presenting live. So first off, who is GAP? GAP is the Global Allergy and Airways Patient Platform. We were founded in 2009, and we are a global umbrella organization representing 150 patient advocacy groups all over the world in allergies, asthma, and atopic conditions and airways conditions like COPD. Today, we are a global network that works together alongside HCPs, as well as other professional societies and governmental organizations, non-governmental organizations, to improve patients' quality of life. We have 4 key mission pillars: disease awareness, disease education, advocacy, and research. And together we are that global collaboration and voice of the patients that are living with conditions like asthma and COPD. And we also provide support specifically to individuals as they're trying to navigate their condition no matter where they are in the world, because oftentimes patient advocacy doesn't exist or looks very differently in different regions of the world. Our overall goal is to create community engagement and capacity building with the patient advocacy community, representing the more than 1 billion people on the planet living with these conditions. And today I want to speak specifically about the Speak Up for COPD Coalition. And who we are is a coalition of community stakeholders in COPD led by GAP, that you can see here, but it is industry partners, it is professional societies of a multidisciplinary team, and it is other nonprofits that are focused on the impact of COPD in the community. And our overall arching goal of the Speak Up for COPD Coalition is to elevate COPD as a public health priority. And why is this important? Because we know that COPD, again, is a disease that is often under-prioritized, underfunded, and undertreated. It impacts about 400 million people worldwide and is the 3rd leading cause of death worldwide, with over 3 million deaths per year attributed specifically to COPD. And it is actually a combination of multiple conditions. So it's not necessarily a single condition, but a spectrum of disease that includes emphysema, chronic bronchitis, oftentimes characterized by restriction in airflow blockage, and related breathing problems, shortness of breath, wheezing, whistling when breathing, persistent cough, chest tightness, and frequent respiratory infections with the production of mucus or phlegm are the most common symptoms. And there are specific risk factors for COPD, including genetics, early life events like premature birth, or lung injury, respiratory infections, tobacco exposure, and environmental exposures, both in the workplace and in the community at large. So again, it's one of the leading causes of hospital admissions globally, and it's estimated that 425 people die of COPD each and every hour, with 40% of those impacted with COPD actually having to leave the workforce prematurely. And COPD is costing the global economy over $4 trillion between 2020 and 2050, without the investment to really know what are the effective interventions and treatments that could reduce this burden of morbidity and mortality. So here on this slide, you see how COPD is actually impacting individuals and societies. With 80% of COPD patients living in low to middle income countries, there is a significant emphasis on the factors impacting in that area. We know again that it has significant impact on people physically with their abilities to carry out daily activities of living and declining quality of health, as well as emotionally. There are oftentimes feelings of stigma, shame, blame, and guilt, especially in the 70% of those living with COPD who have a smoking history. And then economically, we know that this impairs productivity, it increases absenteeism, and has a significant result in loss of income for families impacted with COPD. So again, you've seen here, and it's reiterated, but the cost of COPD is continuing to increase significantly, estimated to be $4.8 trillion by 2030 and greater than doubling over the last 20 years. We also see that 2 out of 3 COPD patients of working age actually have to reduce their productivity, take early retirement, and therefore diminish their tax revenues. So the impact to society is significant and can no longer be ignored. We just did a recent poll of over 14,890 members of the public across 14 countries in 2022. And what we saw is that unfortunately only 55% of the public actually knew COPD was a lung disease. So greater than half, or almost half, did not know. And then 1 in 3 of the public believed that COPD had extreme burden on the country's healthcare system, of those that actually even knew what it was. So I think that this shows that there's a need for greater awareness, but also a need for greater prioritization. So here again, you can see that the time is now to speak up for COPD. And if you scan this QR code, you'll learn more about the coalition and our efforts to work together to raise public awareness and drive policy change to truly address the burden of COPD. We believe that we agree with the statement here that once informed about the burden of COPD, about 60% of public health officials believe that governments could do more and should do more to prevent the death and hospitalizations from COPD. And as I mentioned earlier, the global inequalities of COPD cannot be ignored. We note that 1.5 to 3 times more prevalent in low socioeconomic status communities, and 23% of all COPD deaths are in LMICs with indoor air pollution. So indoor cooking and biomass fuels are a significant contributor to COPD death. And again, over 90% of deaths under 70 years of age are in LMICs. So this year alone, we've created a global state of COPD report that you see reflected here. We launched it in September at the GAP Summit and at the ERS with a number of activities here on your left. And this is a global report that takes a look universally in a short 6 to 8 pages around the global burden of COPD, but then does a deeper dive into 10 specific countries and the impact of best practices, but also what needs to be changed to address COPD. And then we took on a portion of work in addition to the Copenhagen Institute for Future Studies, who's hosting us here today, to look at the large and growing burden of COPD, estimated to be $600 million by 2050. And again, that investment at over $4.3 trillion, leading the third leading cause of death globally. And in this work with the Copenhagen Institute, we wanted to take a look more in depth at country policies, health policies, and its impact on COPD. So the vision here of the COPD Index is to effectively prevent and manage through innovative policies, equitable care, global collaboration, and heightened public awareness. And you can see that this impacts always patients at the very center, but also health systems, policies, and societies. So we took a look at 34 different countries that are represented in this slide. And in these countries, we actually evaluated health policies across 45 different indicators on the next slide. These 45 indicators bucketed into 5 different categories, creating over 1,500 data points analyzed. And you can see them bucketed under policy context, access and care coverage, health system characteristics, disease burden, and environmental factors. This slide gives the overall rankings of the countries once those 1,500 data points were evaluated. And what you can note is that yes, Australia, United Kingdom, and Finland are over 70% in their total score. So they are performing best out of all the countries evaluated. However, out of the 35 countries, there was not a single organization or entity that rated higher than 71.5% across all 5 domains. Moreover, what you see is that there are notable countries missing. So countries like the United States of America, where there was inadequate data to even evaluate where they would stand in this index. You also see the significant decline in countries like Poland, Belgium, Latvia, China, and India, where again, less than 60% of the indicators were achieved for having good policy in place to really address the burden of COPD. So the summarized findings of the report are here. And again, the full report is a PDF of several hundred pages with country profiles for each one of these countries. But at a high level, what we saw is that there's insufficient implementation of policy and guideline adherence across the board. Global guidelines are updated annually in this space by GOLD, and yet oftentimes are at least 7 to 10 years lagging in implementation. Furthermore, tobacco control policies were in place, but oftentimes not sufficient on the implementation to be fully effective in driving down the use of tobacco. The relationship between care sectors needed to be further explored. It seems as though, again, throughout the care sector, we're operating in silos, and that is costing us time in diagnosis and effective management of COPD. There are very high societal costs and knock-on effects, especially in communities of poor socioeconomic status and greater inequities across the board. We noted the potential to improve allocative efficiency in all healthcare systems, as I mentioned earlier. So there was not a single system that we could uphold to say they are doing everything as they should be doing to reduce the burden and the morbidity and mortality of COPD. The data doesn't always reflect those real-world experiences. In doing interviews with patients and healthcare providers in the countries, what we found is that while the policies may be in place, the actual implementation or enforcement of those policies was less than optimal. And the importance of an integrated approach to prevention, diagnosis, and treatment of COPD is very evident in the COPD index findings. We need to start much earlier over the course of one's lifetime, looking at integrated lung health and what we can do from birth to grave to, number one, prevent COPD, but once it is that those risk factors are there, to intervene and slow the progression of disease. So as far as the Speak Up for COPD Coalition, we just came off of Speak Up for COPD World COPD Day, where we participated in a number of events, one being the Pass the Baton presentation, where we had 24 hours of presentations all across the globe on the importance of activity in COPD, and also highlighting the burden, as you see here in the reel, around the impact of COPD in the equivalent of populations of different cities across the world. We developed a social media toolkit that was utilized by all of our 150 member organizations, as well as the partners at the bottom of the screen. And we do not have full metrics, as this campaign will continue throughout the remainder of November. But what we do know is that it was trending on LinkedIn, X, and Facebook on the day in the top 10 across all of those channels. So how can you get involved? Number one, if you have a personal connection to COPD, just as I do, we would encourage you to submit your story. We are gathering stories at the Speak Up for COPD Coalition.com website, and you can learn more there about how to submit your story or contact us. You can also follow and share the content on our social channels, Facebook, X, and LinkedIn, as I mentioned earlier. And you can click on the link there to lend your voice. We are hoping to get 10,000 signatures by the end of 2024 to demonstrate to public health officials that there is a strong, active advocacy community who want to see COPD elevated as a public health priority. And then you can share the report of the global state of COPD and or utilize the COPD index, which is a valuable resource, will help us to have more specific and targeted conversations with policymakers in elevating and addressing this public health pandemic. Thank you so much for your time and appreciate your comments or questions.
Muchas gracias, estimada doctora.
Thank you so much, dear Dr. Winters.
A efectos de la agenda, queríamos
Due to
realizar
schedule
unas
constraints,
preguntas,
we
preguntas que han tenido
wanted
bien
to,
dejar en espacios parlamentarios, etcétera.
due to our agenda, we
Una
wanted
de ellas
to
es
ask you some questions
si
that
existen
were
estudios
left in the Q&A. And
concluyentes respecto al
first one is
impacto
if
del
there's a
COVID en
specific
el
study
COVID.
regarding the impact of COVID on COPD.
I'm sorry, Stephanie, is someone posing the question? I didn't hear it.
Yes, yes.
Sí, la pregunta era
The
si
question was
estudios
whether or not there are any
concluyentes
specific
respecto al
studies,
COVID-19
specific research on the impact of COPD on specific impact of COVID-19 on COPD.
Okay, yes. So there is ongoing work around the impact of COVID on the COPD community. However, much of this data is not yet been published in the public domain. What we know is that those that were living with compromised lung health were at further complications from acute COVID and consequently have also suffered more long-term lung progression, damage and progression over the course of time. So we often saw that again in the early days of COVID, this was our higher risk community who were being hospitalized and having death due to COVID. Now, what we also ended up seeing is that as time went along and people were utilizing more prevention methods and social distancing, hand washing, wearing of masks, that there were fewer cases of high-risk individuals, fewer exacerbations of things like asthma and COPD. So in some ways, the pandemic was beneficial for the COPD and asthma community due to the lack of social integration. However, we know that the mental health impact of COVID was quite heavy on this community as well.
Muchas gracias, estimada doctora.
Thank you so
Winters.
much, esteemed Dr. Winters. We know that you have to leave earlier because of a personal issue, so we thank you for your important contribution and your presentation. And well, we will now we are happy to give welcome to Dr. Sarah Rylance, who is in charge of the WHO Initiative for Chronic Respiratory Diseases. She'll be talking about COPD and chronic diseases, as well as work organized for chronic respiratory diseases.
La doctora Riliani nos acompaña el día de hoy en representación también
Dr.
del doctor
Rylance
Luis Castro,
today also
enviado
represents
especial del
Dr. Liz
Organismo
Castro,
para Enfermedades No
who has been
Bienvenida,
sent by
estimada doctora Riliani,
WHO
con su presentación.
to talk about non-contagious diseases. Welcome, Dr. Rylance. Go ahead, please.
Thank you. Can I just check firstly that you can hear me and that you can see my screen? Yeah, great. Okay. In that case, good evening from Geneva. It's a pleasure to be here with you today. And as has been mentioned, I'm not Jose Luis Castro. Unfortunately, he is currently on an aeroplane. And so although he would very much like to have joined this session, he was not able to join, and he asked me to attend on his behalf. So my name is Sarah Rylance. I'm a medical doctor. I work in the non-communicable disease department at WHO headquarters, where I lead the work on chronic respiratory diseases, and this includes asthma and COPD. So I'm going to talk today a little bit about the work that we do at WHO, the mandate for our work from the countries that we are working for. I will talk a little bit about Jose Luis Castro's role, and hopefully that will provide sort of some overview and context relating to COPD for you. So Tonya has already highlighted the huge burden of COPD. I would just like to emphasize this. So my work covers asthma and COPD. And really, we see this is a huge global burden. So 500 million people are living with asthma and COPD at the moment. COPD and asthma together cause over 4 million deaths every year. And if we exclude COVID, then COPD is the third leading cause of death. When the 2021 statistics, which are the most recent ones that we have, are published now, COPD is the fourth leading cause of death, but this is due to the massive skew that is due to COVID deaths. So third leading cause of death. We know that the majority of premature deaths, so deaths in those under the age of 70 years, occur in low and middle income countries. And asthma, although it doesn't cause as many deaths as COPD, it's one of the most common chronic conditions in children and has a huge impact in terms of morbidity rather than mortality. And we know that we have effective treatments for both of these conditions. And in WHO, we have something called the best buys. So these are considered the most cost-effective interventions for tackling non-communicable diseases. And we have best buys for asthma and COPD, yet these are not available in many low and middle-income countries. Our work in WHO is guided by the general program of work, and we are now on the 14th general program of work, or GPW 14 we call it. This program of work has three different goals to it: to promote health, to provide health, and to protect health. And really the work on asthma and COPD links very closely the work streams within promote and provide. And this is because, as Tonya has already alluded to, risk factors for asthma and COPD act across the life course. And so we know that many of the things that cause new cases also worsen existing disease. And I have put some pictures onto this slide just to highlight, I think, some of the most important causes. So we know, for example, that if that your lungs are developing throughout life, but they're starting right before you're born, while you're inside your mother when she's still pregnant with you. And so if you have insults, or if your mother is exposed to things that affect the way that your lungs grow and develop, then this will have an impact on your lung health later on in life. If as a child you are exposed to things which will affect the way that your lungs grow and develop, so for example, if you are exposed to tobacco smoke, to air pollution, to serious respiratory infections, then this will also stop your lung growth and development and mean that as you go through life, your lungs don't reach their full potential. They don't grow to their full size. And obviously then as you move through adulthood, still exposure to tobacco, to air pollution, to infections, these are all things that can impact your lungs and can lead to COPD. So it's very important when we're thinking about COPD to think about it in a holistic way, not just focusing simply on diagnosis or treatment. We have to think about prevention as well as diagnosis and management, and really look across the life course and look at how these different things interact. So we have communicable diseases or infectious diseases that interact with non-communicable diseases. We have risk factors, we have, all of these things are really important to consider. So at WHO, our work is governed by our member states, by the countries that are telling us what the priorities are. And so work on chronic respiratory diseases and COPD particularly are led or really influenced by two major mandates that we have. One is the Global Action Plan for the Prevention and Control of Non-Communicable Disease. So this is something that was launched quite a long time ago now, started in 2013. The action plan was originally till 2020 and then has now been extended to 2030. And in this action plan, we have some targets. So 25% reduction in the risk of premature mortality from non-communicable diseases by 2030. And as I said, premature mortality is considered a death in someone before the age of 70. And the non-communicable diseases include cardiovascular disease, diabetes, cancer, and chronic respiratory diseases. Then we have a target on availability of medicines and technologies. So an 80% availability of affordable basic technologies and medicines required to treat major NCDs in public and private facilities. And there's also a target relating to the use of tobacco, which is obviously very relevant for COPD, a 30% relative reduction in tobacco use. Following on from the Global Action Plan, we then have the Sustainable Development Goals, which I'm sure many of you are familiar with, and the 2030 Agenda for Sustainable Development. And within this, again, we have similar targets. So by 2030, to reduce premature mortality from NCDs through prevention and treatment and promote health and mental health and well-being. We have another target about access to care, so achieving universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality and affordable medicines and vaccines for all. And again, another target relating to strengthening tobacco control. So these are strong mandates from the member states that tell WHO what we should be doing, that really clearly anchor chronic respiratory diseases within our overarching non-communicable disease agenda. So this guides our work at WHO, and really the aim of the work we are doing is to support an integrated approach to chronic respiratory disease prevention, diagnosis and management, particularly focusing on the primary care level, and trying to ensure that key diagnostic tools and medicines are part of universal health coverage and therefore are available for everyone. As I've said already, the mandate is part of the broader non-communicable disease agenda. We have a strong mandate to do this. And this global programme of work, the GPW14, is split into three main areas of work. So we work on global leadership and partnerships. We have normative work, which is really focusing on developing guidelines, synthesizing evidence, developing data products, etc., and then tailored country support. And I'm going to talk about the first two of these just briefly to give some idea about what we're doing. So Jose Luis Castro, who was supposed to be here today instead of me, has recently been appointed as the WHO Director General Special Envoy for CRDs, for chronic respiratory diseases. And this is a very important role, and it's very significant for chronic respiratory diseases because it really shows how seriously WHO and the Director General is now taking this issue. And I've put here on the slide to share with you some of Jose's main objectives within this role. So particularly to raise awareness on chronic respiratory diseases, and particularly to help to deliver and develop key messages ahead of our 4th high-level meeting, the United General Assembly high-level meeting on prevention and control of NCDs, which will happen in September next year. So this is a key event for non-communicable diseases, and Jose will be working hard with stakeholders to try and ensure that chronic respiratory diseases are well represented. Also, he will be working with civil society organisations and people living with asthma and COPD to understand and amplify their experiences. He will be engaging with member states to really try and support our work and to encourage the integration of prevention, diagnosis and management of chronic respiratory disease, particularly within primary care and health benefit packages, and also to engage with professional organisations and donors really to try and support this work too, because we need money and we need support to be able to drive this work forwards. Just a word to World COPD Day, which, as Tanya mentioned, was a couple of days ago. So as part of this leadership role that Jose has taken, he wrote together with our Director General, Dr. Tedros, a piece about the importance of chronic respiratory diseases, which I think is an important message again on how elevated now this area is within WHO. And I think it's a great piece of communication. And in parallel to this, we also produced something called Science in 5. So WHO produces short 5-minute little clips about various different topics. This was something that really was born during COVID. There were lots and lots of Science in 5 episodes that were produced around COVID, but there are other topics now that we are dealing with. And so we developed one on COPD, which if you're interested, there are QR codes here that you can scan so that you can follow this. We also have one on asthma that was produced earlier on in the year. But again, really the aim is to try and just elevate and make people aware. So many people do not know what COPD is, despite it being such a common problem and an important cause of death. So these were a couple of things that we have done from our side on COPD Day to try and elevate awareness and highlight the importance of this condition. I wanted to speak very briefly, mindful of the time, about GARD, the Global Alliance Against Chronic Respiratory Diseases. This is a global network that's convened by WHO. It's a network of professional organizations, civil society, different non-governmental organizations, all working together with the vision of a world where all people breathe freely. And really, the goal of the work is to try and reduce the global burden of chronic respiratory diseases, particularly focusing on lower middle income countries. We have 46 member organizations at the moment, but we are looking to expand membership. So if there are any respiratory organizations that would like to join, please, again, there's a QR code. You can follow this to find out more information and how to join if you're interested. But the objectives of GARD really are to raise awareness and build support. This is very important, and also to promote networking and knowledge sharing between the different organizations so that we can really work together as a community to accelerate progress on asthma and COPD particularly. And then lastly, I wanted to just mention that obviously at WHO, a large amount of our work is on developing standards and guidelines. So we are at the moment updating guidance for asthma and COPD, diagnosis and management, particularly focusing on primary care. We're updating the Package of Essential Non-Communicable Disease Interventions, or PEN, which you may have heard of. We also have some products that we produced this year summarising the current knowledge state on tobacco and COPD and asthma. We have work as well relating to air pollution and health, because obviously this is an important issue as well. And some data products, so a STEP survey module looking so that countries can look at disease burden, and also indicators for facility-based monitoring, particularly focusing on primary care, to try and allow countries to monitor the progress that they are making if they are when they are implementing chronic respiratory disease programs within primary care. So these were the main, just a snapshot, if you like, of a few of the pieces of normative work that we're doing. So I think that I am just about finished, but what I wanted to finish by saying was I've given you a very quick skip through of the mandate for our work. We have strong commitments from member states on non-communicable diseases, and chronic respiratory diseases are an important part of that. So we have a mandate for the work. It's well aligned with our 14th General Programme of Work, particularly where it relates to primary healthcare and universal health coverage. And we're working hard now to try and provide some global leadership, and particularly collaborating with partners to make progress in this area. The appointment of Jose Castro as Special Envoy for Chronic Respiratory Diseases is, I think, very timely and very important. and it will help us to grow and support the technical work, which is ultimately what WHO's role is, to provide technical work to support our member states. The importance of an integrated approach, I think, can't be emphasized enough. It needs to be, chronic respiratory diseases needs to be integrated with non-communicable diseases within primary healthcare, and we really need to focus on prevention alongside diagnosis and management. 500 million people are living with chronic respiratory diseases, so it has to be available at primary healthcare level. This can't be something that's managed by specialists in tertiary institutions. To reach the 500 million people that need the care, we have to make sure that it's well embedded into primary healthcare. So I will stop there. I'm happy to take any questions that you might have, and thank you once again for the opportunity to speak today.
Muchas gracias, doctora Rilance. Agradecemos su importante
Thank you so much,
ponencia.
Dr. Rylance. We thank you for your presentation. There have been some questions that were left in the chat. So for Dr. Tonya, who is still here with us, we have the question of whether or not there are positive strategy to limit tobacco use regarding COPD.
Yes, yes, there is significant work that's being done across the globe in tobacco cessation. Again, if you look at most of these efforts are being done at a national level, but also at WHO, there's significant work around tobacco cessation programming. And what we know is that, again, across the globe, COPD, about 70% of people have some degree of smoking history. So 1 in 3 never smoked. But again, we know that the impact of smoking is very closely tied to COPD. So we are proponents of tobacco cessation therapies and ensuring that those are a part of essential medications across the globe, as well as behavioral therapy and support for tobacco cessation. Because again, this is like any other addiction, and it is something that someone may make the choice to begin smoking, but very few people that I've ever met living with COPD make the choice to continue smoking. So I think that we have to remove the stigma associated with this and do everything possible to support tobacco cessation.
Muchas gracias, doctora
Thank you so
Winder.
much, Dr. Winders. Another question was related to the presentation of Dr. Rylance. The new generations are receiving a very contaminated planet. So what specific care or screening should be guaranteed in the first years of life for the prevention of these chronic respiratory diseases?
Thank you. I mean, I think it's a very good point. There are lots of insults to your lungs, as I highlighted throughout childhood and adolescence into adulthood. In terms of what screening should be available, I think it's very difficult to say that there are particular tests that should be offered at particular times. But I do think that one of the things, and it's a very simple thing, but I think we're not so good at it, is making sure that people are aware of what is normal and what isn't normal, and encouraging people to seek care or medical review if there are persistent symptoms. I'm particularly thinking later on in life when people develop often, breathlessness as a symptom of COPD. We know that many people live with this. They don't seek care. They think that this is normal. It's part of getting older, particularly if they've smoked. They maybe feel like, well, this is a normal thing. And so they're late in seeking care. And then this means that by the time that they seek care, it's difficult to help. We know that many of the interventions need to be done early on. So I think more than having specific formal screening at particular times, I do think that making sure that people are aware, and this is where, Tonya's work with the Speak Up for COPD campaign is great, raising awareness about conditions like COPD and asthma too. In high-income countries, everyone knows about asthma, but in some of the less resourced countries, if children are coughing or breathless, the assumption is that they have pneumonia, they have a respiratory infection, even maybe that they have TB. But asthma is very, very low down on a list of differential diagnoses. So again, raising awareness across countries that these conditions exist, these are the kind of symptoms, and encouraging people to seek care because there are treatments that are effective and affordable and can really have a positive outcome, but they will be more effective if they're implemented earlier. And we know this. So this would be my response to that question. Thank you.
Muchas gracias, estimada doctora Lilians y
Thank you so
doctora
much, Dr. Rylance and Dr. Winders. We've seen the repercussions that chronic respiratory diseases and COPDs have on health systems, on the populations, especially in countries of low income. We have seen the initiatives that exist globally to fight these issues. We thank you for your presentations. We know that you're busy and you have to go. And well, thank you so much for your attendance, and thank you for your very interesting contribution.
A continuación, vamos a dar la
Now,
bienvenida al
we are
doctor
going
Andrés
to welcome Dr. Andrés Locke, who offers us a general vision of the treatment, of prevention, and especially of the stigma reduction. Dr. Locke is a doctor specialized in pulmonary medicine from the University of Copenhagen. He has worked as a specialist in the hospitals of Aarhus and Veil with a broad clinical experience in COPD.
Adelante, doctor.
Go ahead, Dr. Locke.
Thank you. And yes. So thank you for the kind introduction and the invitation to speak today. And I will focus on treatment options in COPD, but first I will give a short introduction into the patient perspective and also some Danish perspective on COPD. As the previous speakers did mention, we just had World COPD Awareness Day 2 days ago. It's a recurrent event that's been happening for 22 years now, and I think it's important that everyone knows about this and continue to giving the message to everyone they know, so that people will come and hear about COPD and have their lung function measured. We have also heard from the previous speakers about that COPD is ranking 3 among the most common causes of death. I have brought this way of presenting death globally, and as you can see, 3 out of 4 deaths that occur are actually due to non-communicable diseases or to non-communicable causes. And I think that it's important to highlight that almost all of these diseases that you see in the box, non-communicable diseases, are diseases that are caused by the way people live. It's caused by too much smoking, due to inactivity, due to eating the wrong things, due to consuming alcohol, and also due to poor living conditions like environmental causes and smoke in indoor smoking, and I think it's important because it's actually possible to almost get rid of these causes if we actually try to. So I think that's very important. Infections are also to some extent possible to get rid of, but it's somewhat more tricky to do that, but it's possible as well. So on that notion, I'll go to this analysis, and I know it's in Danish. It's just to highlight the that it's rather new. It's 1 year old, as you can see in the top corner. It was a statement posted in all the medias in Denmark saying that actually COPD is the #1 killer in Denmark. It's actually 6% of every person who die in Denmark die from COPD. And if you add people who die with COPD as a co-condition, it's 1 in 10 of everyone in Denmark that die from COPD. So even though it's ranging 3 globally, there are huge variations due to different smoking patterns, due to different environmental patterns, and so on. And to highlight the that a lot of the death are due to people having bad life conditions, I'll show you some Danish data showing the development and life expectancy over the course of the last 35 years. And this graph is showing the middle life expectancy for men, and the lowest graph is actually showing the 25% with the lowest income, and the upper graph showing the 25% with the highest income. And as you can see, it's a positive story. If you look at the low income, they have actually increased from around 69 years to 74 years. But the bad news is that the rich people has actually increased even more from having the same starting point as the poor people at 74 years and actually increasing up to 84 years. So the difference, the gap in life expectancy is increasing, even though we think we are very wealthy country, and even though everyone is talking about we are trying to reduce inequality, but actually it's increasing. This is 50% of the population we're looking at. And the same is true for women, as you can see. It's not as great, the gap, as in men, but overall it's 8.5%, showing that these people who are poor are having very bad odds to improve as fast as rich people. So I think it's very important because we have to deal with that in every country. And this slide I just brought to show you the prevalence of COPD in South America, and it's roughly 10%. And I think in some places it may be rather inaccurate due to difficulties tracking the exact amount of people having COPD. But so I think it's numbers that are inaccurate to some extent, and I think it's actually higher in reality. So 1 in 10 in South America. And we have heard a little about what happens when you have COPD on the symptom side. What happens inside the lungs are 2 things, mainly that the alveoli, that the lungs are actually destructed, causing the lungs to grow and having difficulties to stay inside the thorax. And that's what causes the breathlessness. And we have also heard that people are having cough and phlegm, and that's due to inflammation in the lungs with airway thickening and mucus production. And we have also heard some of the causes. The main causes: smoking, air pollution, and also due to genetic susceptibility. And if you want to diagnose COPD, it's actually possible everywhere, I would say, because you just have to talk to people. There are three main things that you need to consider. One of them is during a spirometry, and that's the only equipment you actually need. And then if people have symptoms, mainly dyspnea that is progressing over time, and also a history of risk factors, and we have heard what risk factors to highlight in the talk. So spirometry and a history of symptoms and risk factors. That's what you need to give the diagnosis. And why is it important? We have heard a lot of people die, but actually it also impacts their life to a great extent. This is a survey showing that mean tasks in everyday life are actually getting more and more difficult, like walking a single flight of stairs. 2 out of 3 complain about that. Getting washed or dressed, maybe preparing a meal, 1 in 3. Even to talk could be giving you symptoms, leading to social problems, 1 in 4. Or even if you're doing nothing, just sitting or lying in your bed, 1 in 5 are actually reporting symptoms. So it's a huge impact on everyday life. Sometimes COPD could lead to an exacerbation of symptoms, often due to infection in the lungs, causing the lungs to be further damaged and lung function decreasing. This would automatically lead to less physical activity that could cause social isolation, impacting the mental health, and of course also the quality of life, and making you more prone to have further exacerbations and maybe even die. Luckily, if we look at the goals for treatment and what could be done, then it's divided in 2, and I think it's important to highlight that most of the things you can do in COPD treatment will actually impact both of these factors. So of course, ultimately, we want to reduce risk, reduce mortality, and reduce disease progression. But at the same time, very important to relieve the symptoms so that patients could be active and live a better life. And most treatments actually impact both of these factors. That often is a tendency to talk to patient about symptoms because that's what they experience, but it's equally important to highlight that in the same manner and to the same extent as when you reduce blood pressure, reduce cholesterol, reduce blood sugar, you would impact mortality and disease progression. So it's not just to relieve symptoms, it's also to relieve, to reduce risk that you treat people. There's a lot of different kinds of treatments that could actually impact the occurrence of exacerbations in COPD. And I have only on this slide highlighted the other box because the 2 main things that work in COPD is smoking cessation and rehabilitation. And I would say that every country could afford these 2. So even if you have a bad economy, it's possible to make sure that these 2, which are the most important, could be available on a broad level. Then you could discuss the medication if you could afford them, the vaccinations. But I think these 2 are very easily to implement, but it's unfortunately rather seldom that it's available in a broad scale. When speaking medication, it's actually comes down to 2 steps when we talk inhalation medication. You could give bronchodilators acting for 12 or 24 hours, and we have 2 of those, and it's recommended to give them on the same time if possible. If you only have one available, it would be medication, the ones that I've called LAMA, because the LABA part is actually dilating the airways so you could breathe out more easily, and the LAMA part will make the airways restrained from contracting again, so they would be as open as possible. And the LAMA part is the best of those 2 in terms of reducing risk of mortality and exacerbation. So if you only can choose one, I would go for the LAMA, but I would definitely combine them. And if you still suffer, and that's, forgot to mention that this is mainly for patients without exacerbations that you would treat in that way. So that's focusing on symptoms. But if you experience exacerbations, you would for sure like to add the ICS that would take away inflammation and are the most impactful on reducing exacerbations and reduce mortality. So that's actually how to treat from a inhalation perspective. When it comes to this, when it comes to the stigma of COPD, at least in Denmark, and I think in most Western countries, there is a strong relation to smoking and the way we think COPD. But actually, smoking can lead to 3 equally devastating and deadly diseases. One of them is lung cancer, and we often talk of lung cancer, something that is coming from the outside. You are suddenly struck with lung cancer. So we take away the shame because we feel very sorry when people get cancer. You could get a heart condition, and everyone is afraid of heart conditions. So the danger overrules the shame because everyone knows they have to act very fast. And then you could develop COPD, and all of a sudden it's your own fault. And I think it's problematic because they're equally deadly, as I mentioned, and the causes are equally the same of all these conditions, but we think of them in a different perspective, and it's important to always mention this so that eventually people would we might be able to change the story of COPD. So what do we need to achieve this on a broader scale? And I think we need a plan, and I've just put in the latest plan from the European countries. It's called Joint Action to Prevent Non-Communicable Diseases, and they're actually putting some money and effort into making a plan on how to actually do it. And I think the plan should have these points that you have to write down how you would deal with COPD on a national perspective, what you want to achieve, and how you will get there. And one of the points should most certainly be to raise awareness, because even in it's all the same around the globe. The awareness of COPD is very low, and that's why people are not, one of the reasons why people are not seeking healthcare professions. Also, there is a huge impacts in legislation or policies of how to give clean air to people, how to raise the prices of tobacco, or even making it illegal. So that's also a handle that is easily pulled if you want to do it. The most important thing is maybe to proactively go out to talk to people, to offer them spirometry, to find them early on, because then the damage is less, and you could actually prevent the people the disease from progressing, and that would be very beneficial in the long-term perspective. But this is nothing worth if you don't have a very throughout plan of how you'd implement these programs, and also have some measuring points so you can see if you progress as you planned. And I have put the green arrows in the side to show that the measurements should make you think or rethink your national program. And is your plan okay? Does it need adjustments? And make the adjustment, and then go all the way to the bottom again. And finally, I'll just show the CPD index, because I think it's very important, because now we could actually start to talk of the impact of CPD on a national level between countries. So I think it's a very important work that, of course, needs to be further utilized throughout the world. And finally, I would like to show you this slide, because I think it's important to realize that if you have a problem, then you have to think differently if you want to do something about it, because that's the only way to fix the problem. So thank you very much for your time.
Muchas gracias, querido doctor Lud.
Thank you so much, dear Dr. Locke.
Agradecemos a todos los
We
ponentes
thank all the speakers
que han presentado el día de hoy.
who have made their presentations today.
Vamos, Estefany, tú puedes.
Agradecemos a todos los ponentes por haberse
We thank
presentado el
all
día de
the
hoy.
speakers for their presentations today. It was also enriching to have this exchange of knowledge that took place today.
Asimismo, queremos
Likewise, we wanted
asistencia de autoridades
to
sanitarias
thank
que nos hayan
the
acompañado
attendance of the organizations that were part of this
Bueno,
exchange of knowledge in this
contaron con
webinar,
nosotros para participar como comentaristas del diálogo e
who
intercambio de ideas
were
a los
here
temas
as
abordados.
commentators,
El
participating in the
doctor
exchange of
Óscar
knowledge. We
Gayoso
have, for
Cervantes,
example, Dr.
médico
Oscar Gayoso
neumólogo del
Cervantes,
Hospital
who is a
Nacional Cayetano
pneumologist doctor
Heredia,
from the National University of Cayetano
y
Heredia,
Juan
and
coordinador del posgrado de
coordinator
especialidades
of the
moleculares
postgraduate
del Hospital
program
Heredia.
of
También nos
the
acompaña la doctora
Perón
Laura
Cayetano
Nicolau
Heredia
Hernández,
University. We also
docente
have
de la
Dr.
División de
Laura
Neumología y
Nicolau
Terapia
Hernandez, who is
Intensiva del Escuela de Medicina de
a
Hopkins
doctor in
University y con afiliación al
from Hopkins
Departamento de Salud y
University,
Ingeniería
and
Ambiental en la Escuela Rumberg
in
de Salud
charge
Pública de
of
Indiana.
the
Para iniciar el
environmental
diálogo,
health
cedemos la
school in
palabra a
the
nuestros
Johns Hopkins
panelistas
University. We
invitados
will give the floor to
para
our
consultas,
commentators
comentarios e intercambio de
for
experiencias sobre los temas
questions,
presentados por nuestros
comments, and exchange of
paneles
experiences
anteriores.
after the
Adelante,
presentation of
doctores,
our dear
por favor.
speakers. Go ahead, doctors, please.
Bueno, sí, buenos días a
Yes,
todos.
well,
Muchas
good
gracias
morning,
por la
everyone. Thank
invitación
you
y
so
por
much
estar
for
aquí
the
con ustedes.
invitation to be here with
Bueno,
you.
como un poco
Well,
de información acerca de nuestro
as
grupo de
a little bit of
investigación
information
en Johns
about our
Hopkins,
research
nosotros
group,
nos
in Johns
enfocamos en
Hopkins, we
enfermedades
focus
respiratorias
on
crónicas, pero sobre
respiratory
todo
illnesses that are
la
chronic, but
calidad de aire, ¿no?
also
Como uno de los
specifically the
factores
quality of air
de
as
riesgo
one
principales, como ya
of
hemos
the main
visto
risk factors,
en las
as we have
presentaciones
seen in the presentations that we have had this morning. We work in different countries, Peru included, where we have been working for over a decade. We have conducted different studies focused on air pollution, both inside the home as well as environmental. And in Puno region, we have undertaken controlled screenings and interventions to reduce the exposure to in-house pollution, which is one of the main risks for COPD for low and medium income countries, as you may know. And what we have done is we have measured how the intervention of kitchens with liquid gas or petroleum can can reduce this pollution and whether there are benefits to health. And right now, we have a project that we are undertaking with researchers in the Peruvian Cayetano Heredia University, as well as collaborators in Emory University, that has as its main objective to establish a research center and training in environmental health here in Peru. And one of the main activities that we have undertaken in this project, which I think is an important activity, has been to establish a monitoring network for air quality in all of Peru. We right now are installing monitoring of low cost in the entire region in all the departments in Peru, because one of the gaps in research that we have seen is a lack of data on air quality. And so what we want to do with that is to create awareness in people regarding the quality of air in regions where no such data exists, and with that, to be able to create effective mitigation strategies to be able to improve the respiratory health of people.
Muchas gracias, doctora Nicolau.
Thank you so much, Dr. Nicolau. Dr. Gayoso is having some technical issues, so we shall continue. Now, we shall continue with the comments based on the questions that were made by the participants. And we will do our best to answer all of the questions that were left. Remember that we value each and every one of them, and that also you can contact us through the email if your questions are not answered due to time constraints. For that, ask the speakers and commentators, well, the commentators, to turn on your cameras, please. So we know that chronic illnesses are an example of the fact that health should be at the center of policymaking. While there is a global action plan for the prevention and detection of non-contagious diseases, but this is not only focused on the health sector. How do we involve the rest of key actors, especially the authorities, to limit the emission of contaminants on international level? Has anything been accomplished in this sense?
No sé para quién era esa pregunta, pero
I'm
puedo.
not sure who this question was, but I can say, yeah, absolutely, Laura.
Bueno, esa es una muy buena pregunta.
Well, this is actually a really good question. In fact, this is something that we think is one of the biggest challenges. For example, in the project that we have in the GeoHealth Hub in Peru, where our main objective is to inform on mitigation strategies. And we have many actors. We're working with Tsunami, we are working with MINSA. But one of the things that we see, for example, is that we need to have further dialogue between all these actors to be able to undertake and implement strategies that are going to be effective and successful. So I agree with that comment. This is a big challenge that we see, and it's one of the things that we have to consider in this project. And we're trying to bring all the main actors to work together because it affects not only a single institution, not only Tsunami. This is also something that the Ministry of Health should be involved in. There are many components, the Ministry of Transportation, so we all have to be working together to be able to implement these strategies and make sure that they're effective.
Muchas gracias, doctora Nicolau.
Thank you so much, Dr. Nicolau. We also have the following question, both for the speakers as well as for the commentators in the room. Despite the fact that these are the countries with the lowest level of emissions, the countries with low income are the most affected ones. Are there any global initiatives to help with this?
Están haciendo unas preguntas súper interesantes.
These
Yo
are all
creo que
very
de
interesting
recontra
questions. I think
interesantes.
they're super interesting, honestly.
A ver, vamos,
All right.
Laura, ¿qué cosa decís
Okay, let's
sobre
go,
esto?
Laura. What do we
Porque
say about this? Because
es muy amplia.
this is a very broad question. Right, can you repeat the question if we are doing any kind of studies of air contamination that are international? If there are any international initiatives related to the pollution emission? Yes, very good question as well. And what we've seen while working in this field is that in the areas where we see the greatest level of air pollution, where we see the greatest level of emission, there are certain areas where those are the areas where we lack the most data and where we lack monitoring. And this is an important point. This is why we are working, for example, as a research group. We not only work in Peru, but we're also working in other parts of the world. We work in Uganda, in Nepal, in areas where there is a high air pollution. So we are installing this type of monitoring with low-cost sensors, which is something that can start collecting this kind of data. Of course, reference monitors are needed to be able to begin this calibration with low-cost monitors, but I think that this is an important aspect and that we need more information in many parts of the world where the exposure is at a very high level.
Yo creo que el tema también iba por ahí, pero
I
más que
think
todo iba
the
por el
topic
tema de
was
justicia social. La pregunta
about
es
that, but
cuál es
also
justicia
in the
social.
sense of social
No
justice.
sé, Boji, tú podrías
I don't
hacer
know,
algún
Boji, perhaps you
comentario
can
relación
make a
a
little
esto, ¿no? Porque
comment about
Anders ha
that
sido muy
because
claro,
Anders
nos
has
ha
been very
puesto
clear.
quiénes son los que más
He
sufren,
told us
las diferencias
who are the ones
sociales
that
más
suffer the
grandes,
most,
y
the
esa habla de
differences are getting bigger, and we're talking about
pone a
Denmark.
Dinamarca, los
Right?
países
Denmark is
escandinavos,
supposed to be one
para
of the
nosotros
Scandinavian
son, ¿no?
countries
Como
who are
un
like,
ejemplo, ¿no? Un norte.
an
¿Algún
example to
comentario,
follow,
por
our North
favor,
Star.
de
So,
Boji
any
y Anders
comment on
acerca
that,
del tema
Boldy and
social?
Anders, on this comment, on
yo
this
puedo
subject,
empezar.
please? Yeah, I can start.
Yo creo que hay movimientos en la
I
parte de
think that
sociedad
there
civil
are
en,
movements on
en
behalf of
varios
civil
países. Eso
society in
probablemente
several
es
different
como visto.
countries. This is what
Más
I've seen.
organizado y estructurado, estamos
That
empezando a ver. Por ejemplo,
are
cuando
organized
estaba
and
participando en
organized in structure. And we could starting to see this, for example, when we were participating in the G7 and the SDG convention in Europe. Several directors of institutions of statistics in these countries were putting on the table the fact that we need to rethink what valid data is and how we can work with this data and its temporality.
pero si queremos actuar en,
But also, if
en
we want to
tiempo de
act
necesitamos
in
información.
temporality, we need information that is timely, and
Nosotros también desde el instituto estamos
we from our
tratando
institute
de ver cómo
are
podemos
also
trabajar y
trying to
apoyar
see
en
how we
ese
can
cambio.
work and we can
Si la
support this
pregunta es
change. And
si
so if the
muchos quieren
question is
hacerlo, sí.
if many want to
Si
do
la
it,
pregunta
yeah,
es si
they
muchos
do. And if the
muchos lo hacen
question is,
estructurado,
are many doing it in a
entonces,
structured way? No,
y
they
ahí
aren't.
yo creo también
So I
como
think
Lara estaba diciendo,
that, as Laura
¿qué
was
consorcio se
saying, what
necesita
sort
desarrollar
of
para poder hacer
consortium you need
eso?
to develop
Eso es
to
importante.
do this? This is
Pero para
important.
empezar,
But to
trabajar
start
con un
with,
consorcio
you
así,
need
tú
to start working
necesitas
with a
también definir
consortium. You
qué es
need
que
to
quieres.
define what is it that you want.
¿Cómo es ese mundo donde puedes hacer
What is
eso?
this world like where
Porque como
you
siempre
can do that?
decimos,
Because
si
as
no
well
sabes
as
dónde vas,
say, if you don't
todo
know where you're
camino te lleva
going,
a un sitio,
then
pero no es donde quieres ir,
any road
¿no?
takes you somewhere, but it
Yo
might
creo
not
que
be where you want
falta
to
que se
go.
sienten
And
y
I
decir,
think
ok,
that is what
para
we lack.
poder
We need
hacer
to be able
eso,
to say, okay, so to be able to do this,
¿cómo se puede imaginar qué
how
hacer
can
en 5
we
años, 10 años, en
imagine
15 años
this in
y
5,
hacerlo?
10, 15
Pero
years
eso
and
no
do
es
it?
nada que
But
podemos
it's
solamente
nothing
dar
that
a
we
las
can
oficinas
do or
oficiales de los
give
países de alguna forma.
simply
Eso es algo que
through
las
the
sociedades
official
civiles, las
offices
empresas
of
también necesitan
the
ser parte de
companies or
hacerlo.
governments. This
Porque
is something
quizás
that the
mitad
civil
de esos
organizations
datos
also need to do
vienen de
because
actores no públicos.
sometimes half of this data comes from non-public actors.
Anders, creo que querías decir algo, por
Anders, I
favor.
think you wanted to say something, right?
Yes, I think it's it's important to think in two different ways. First of all, we want to have our children to live a healthy life, and so therefore we have to focus on how to get there. And I think some of it will be managed by politicians. They have to make the policies for them to be able to live these lives. But of course, they need the proper input from healthcare sectors and also from patient organizations and other stakeholders to gather all the knowledge and to go in the right direction. But I also think a main point is what do we do with all the people who suffer today? And just to give an example, I just wrote a chapter in the book teaching medical students, and it was the first time out of 32 consecutive books that there was a chapter telling about what does smoking do to your body, and what are the health concerns, and what do you gain from smoking cessation. There's no chapter telling about pollution, there's no chapter telling about physical activity, and there's no chapter telling you, or no education telling you how to teach it to your patients, how to teach it to your children. The same could be in the if you look in the books of school teachers or other educationers, that it's lacking, and if you don't if everyone who's supposed to teach the next generation, if they don't have this information and they don't care about it, then it's almost impossible to give it to pass it on to the next generation. So I think that's could be one very easy achievable goal if we start with that. But of course also the other leg, yeah.
Muy bien, muchas gracias,
All
doctor Luke.
right,
Tenemos
thank you so
algunas
much.
preguntas
We have
justamente
more
respecto a su
questions
exposición.
regarding your
Bueno,
presentation, Dr.
sabemos
Locke.
que la atención
We know
primaria
that
es
the
clave
primary
para la
care is
atención de
key
personas con enfermedad
for
pulmonar obstructiva
people
crónica.
with a
Entonces,
COPD.
por ello,
So,
¿cómo la
regarding
telemedicina
that,
está contribuyendo en
how
seguir
does
mejorando
healthcare
estas
contribute
intervenciones?
to
¿Qué
continue
experiencias
improving these
locales nos
interventions?
puede
What local experiences
compartir?
can you share?
Yeah, thank you for that question. I think you have to engage with the specialists, and they need to come out of their own office and to interact with the GPs, to actually visit the GPs, and to maybe go through a lot of the patients to help making the plans, and to teach them side by side, because I can maybe see, I don't know, 10, 15 patients in a day, but I could visit different doctors and go through 40 patients in each doctor. So I could help much more people by coming out instead of having people referred to me. Secondly, I think there's a worldwide problem with conducting and interpretation and reading or understanding spirometries. So I think there should be a focus from the government to make it possible for GPs or primary care to send people to a place where the spirometry is conducted, and it's also told what the spirometry is showing, so that you overcome that problem. And I think some would say that you just should educate the healthcare professionals, but I think it's a Sisyphus kind of work, because there's a lot of change in the people giving this spirometry, and they are from different educations. So I think it's much better that you have a validated setup where you are sure of the quality, and then you overcome that problem, and then you could focus on the management part. So I think that would be my answer to that.
Y no sé si
Muchas gracias, doctor Lu, por la respuesta.
Sí, simplemente quería añadir
I just wanted to add
que hemos visto nosotros en
that one of the challenges that we've seen in the areas where we work is access to a spirometry, actually. It does not exist. They don't have pulmonary function testing labs, and this is one of the challenges that we've seen in so many areas.
Ok, entonces, muchas gracias.
All right, so
Otra
thank
de
you
las
so
preguntas
much. Another one of the
para los
questions
asistentes, sobre
for
todo
our
con el focus de
attendees,
la presentación del doctor
especially
es,
with
sabemos
considering the
que
focus of Dr. Locke's presentations, that we know that respiratory illnesses affect
a la población infantil.
percentage
Entonces,
of
¿qué atención
the child population. So what special care should be provided to pediatric patients with COPD? And we've seen more cases in the last few years with this, for this populational group specifically.
Yeah, so thank you for that question. And I think it's mainly in Europe, at least, when people or children get COPD, it's mainly due to being born too early, or having a very difficult start to life, and it's often different from the COPD that grown-ups get, because it's due to other kinds of lung injury that is very difficult to actually overcome. But I think the main focus should be to avoid further damage. So it's very important to advise on what kind of work to be done, how to avoid smoking, and also how to avoid especially infections, because it would further increase the damage. So I think it would be much on the prevention part, and not as much on the treatment part, I would say.
Muchas gracias, doctor Luke. No sé si la doctora Nicolau, el doctor Boye tiene algún
Thank you so
comentario.
much,
La
Dr. Luke. I don't know if Dr. Nicolau, Dr. Kaye have any comments.
Yo coincido, ¿no? Digamos, son
I
diferentes situaciones.
agree, right? There are different situations. Children, but I think the message is the same. If you have a patient who is short of breath, then you have to do everything that you have to do. You have to diagnose, and Dr. Anders has been super clear. These are the symptoms. Don't waste time. Just diagnose. See what happens. I was just thinking on the premature babies and all the issues that we have with bronchopulmonary dysplasia, but that's a different group. That's not COPD. But this also implies oxygen dependency, and I think that an issue that was very well proposed by the doctor is all the limitations that people with COPD suffer from, right? This study about how well they can't talk, they can barely dress themselves, they can't get out of bed. This implies so many things, and I really like this comment about the stigma. Yeah, okay, if it's cancer, but if it's something else, and I, 2 months ago, we were in Buenos Aires in the World AIDS convention, and I mean, there are cases where AIDS had been cured. So the person told us that while he had AIDS, he was being stigmatized, but when he was diagnosed with leukemia, on top of that, he moved on to the next level. He was no longer subject to stigma because now it was leukemia. So there's a very important topic here, which is stigma, because it's a vicious cycle. I can't walk. I don't exercise. I don't connect to people. I don't go outside. Oh, it's because I've smoked. It's a whole cycle. So I think that it is really important. This is a topic that I thought was very important because it has faced us off with the fact that it's not among the chief concerns in public health. So if it's not there, then, and despite the fact that it's the evidence is screaming at us, right? The issue, smoke in the house, smoking, pollutants. And this is an issue over the course of life, right? Everything that influences your life in childhood and adolescence, it's going to determine what your adulthood is and your late adulthood is going to look like. That's what I wanted to say, Stephanie. Sorry. Stephanie, if I may. Go ahead, Dr. Bori. Thank you. Well, I think it is really important to add here that these issues that are connected when you have respiratory diseases, and as Laura was saying as well, in many countries we lack equipment, the training, and just the ability to find out what it is. That's what we're working with. And one of the reasons of starting this work, such as the respiratory initiative that we're doing, as well as the report that was mentioned, it was to examine. And of course, we want to look at more countries. But it's also a question about how we work with data. And Laura, I want to talk to you about this a lot regarding what you have on Peru. But a main but for us is dignity. Because, like, why don't we have this sense of maintaining the dignity and the respect for this group of people and patients? And of course, there is something that has to do with the social determinants. Most of them are the poorest group of people in society, and if we want equity and justice, then here we need to promote this here more than in other places. And this is why we also want to promote this part of COPD on how we work with dignity and equity with pulmonary diseases so that we can help more. For me personally, Latin America is very interesting because you have half a billion people who use the Spanish language. So you can go to different countries. You can go to countries that have the same tools, the same dialogue. This can be an area where you can create an example of the fact that, yes, this is possible. You can do it in this part of the world and you can promote this. And I think the opportunity that we often forget about is that a lot of it has to do with scalability. When you want to do this for a price that society can pay, this is where the opportunity happens. There are no excuses. But it's the dignity that we need to remember that is part of what we're promoting. Thank you so much, Dr. Borje. We wanted to also mention TB, which is present in Andean countries. So the question was for Dr. Laura or Dr. Locke. What observations would you give on the COPD that's caused by TB? And in regards what it implies in terms of the increase of this thermo-resistant version of COPD for the prognosis of the quality of life of the patients. Go ahead, doctors.
Doctora Laura.
Bueno, sabemos que
Well, we know that TB
es un insulto más, ¿no? A los
is
pulmones,
one more insult to the lungs,
como todos los otros riesgos que hemos
as all the other
hablado y
risks that we've mentioned and what it can cause if we're thinking on the course of life, as was mentioned. To have TB, what it does is it accelerates this decrease of pulmonary function and accelerates these COPD issues. And this happens in many countries of the world. This is another important risk factor for chronic respiratory illnesses. It's something that we have to consider. Thank you so much, Dr. Laura. I don't know if anybody else has any comment on the matter. Dr. Locke or anybody else? Dr. Calle?
Confirmar lo que dice, ¿no? El hecho de
Just to
que
confirm what she said, the fact that you have tuberculosis increases the risk terribly for you to get COPD. That's how it is. Yesterday, we had a TB webinar with a world report, and Peru had first place in number of incidents. So we're quite concerned. Thank you so much, doctor. To close out, very briefly, we would like to, perhaps on behalf of Dr. Laura, Dr. Locke, we would like for you to tell us what you think are the priorities to take into account when developing national policies or regional policies regarding respiratory health, especially in countries with contexts such as the ones with the Andean region.
Bueno, puedo empezar yo. Sí. Bueno, como he comentado antes,
Well,
yo
I
creo
can start.
que
As I was mentioning before, risk factors that we see, especially in the Andean region, in rural areas, people cook with biomass a lot. And this is one of the main risk factors for COPD. In countries with high income, we know that the main risk factor is smoking, but if we go to other areas, the rural areas where people cook with biomass with that fire, that's the main risk factor, biomass, right? It's above smoking. So that is one of the important strategies, I think, to consider: the use of cleaner fuels for cooking, for domestic use. And then, on top of that, as we know, the emissions, environmental emissions, another very important risk in areas, well, all over the world, really.
Y en Lima, por ejemplo,
And in
que
Lima,
es
for
una de las
example,
ciudades
which
más
is
contaminadas
one of the
de
most polluted
Latinoamérica,
cities in Latin America,
una de las mayores de los mayores los
one
sectores
of the greatest
contribuyen
sectors
una
that
proporción
contribute
significante de
an
esa
important
contaminación
proportion
ambiental
of this
es el
environmental
sector
pollution
de
is the
transporte.
transportation
Entonces,
sector.
estrategias de
So strategies
mitigación
to mitigate
de emisiones vehiculares, esa es
vehicle
una,
emissions is one
una parte muy importante, yo creo,
an
también
important part of it, I believe, to think of strategies for public transportation to be able to reduce the number of vehicles, think of
controles, ¿no? Porque
better controls, because the fleet of vehicles, well, there are many vehicles that are very old, which are the ones that emit the highest level of pollution.
Otro componente donde se
So I
podrían
think that would be
implementar
another
estrategias.
component where we can implement strategies.
Muy bien, muchas gracias, doctora Laura.
Thank you very much,
Doctor
Dr. Laura. Dr. Locke,
Adelante.
go ahead.
Yeah, thank you. Well, I think it's important to address where can we get the most for the least effort, and maybe make a list to see that the effort contra the gain, because then it would be very obvious which points to address the first. I think so. If it's transportation, then of course make a strategy, as we heard. If it's indoor air pollution, you need a strategy to lower that, and so forth. So I think that, and also on the same note, to have a parallel strategy on how to increase the quality of life of the ones who are already suffering, and to stop further destruction of lungs, and in the same way that say, well, we could do rehabilitation, we could do different things that are very cost effective, instead of reaching for maybe expensive treatments, because it would be expensive, and you could maybe reach fewer people with the effort. So I think that would be my strategy, at least.
Muchas gracias, doctor Liu, por el comentario.
Thank you, Dr. Locke,
Entonces,
for your comments.
reiteramos el
So
agradecimiento al equipo de
we
Copenhagen
reiterate our gratitude to the Institute of Copenhagen for Future Studies team, the World Health Organization, our dear commentators and panelists, for your contribution today, as well to everyone who participates in this activity, and that has been possible thanks to the commitment of the Andean and Inter-American Organization. And please follow our public posts on social media. We also want to greet everyone who is joining us today, especially the officials of the Ministry of Health, of the academia, social organizations, institutions, public and private, of Latin American and Indian countries. And on a global level, we have on Network A, Mexico, Paraguay, Peru, United States, Panama, Bolivia, Brazil, Colombia, Ecuador, Guatemala, Uruguay, Venezuela, Chile, and other countries that have been connected, listening to everything that has been talked about today. I give the floor now to Dr. Boyi on behalf of the Copenhagen Institute for Future Studies to give our closing words. Go ahead, dear Dr. Boyi. Thank you, and thank you so much for these 2 hours. You know that I am almost Peruvian, and I'm very happy that we're focusing on the development of Peru and but also the Andean subregion in general. So this, for me, has been a very important webinar that through which we have been able to elevate our work on COPD together with experts and those of us who work in from Denmark, and Tonya Winders, who's part of our work committee, and Jose Luis Castro, who wasn't able to join us today. We're also working with him on the international agenda and with Sarah as well, who is working with him. And I think that, Laura, you are not going to escape from the fact that we're going to work with you in Latin America on this part. So I am very happy about all of this. And also that we had a discussion about root causes and not just the symptoms and the problematic itself. I also think that the part and the construction of these hours is important because it's not something that can be resolved simply country by country. So this is why I say the Andean countries, this is an opportunity to figure out a problem that involves all of you. And on our agenda, it's one of the most important problems, especially when we consider dignity. But those of you who are decision makers, if you want to maintain and improve your resiliency in your population on a health level, then COPD is something that you have to work on. And I also really like this focus, final focus on what can we do. And it is important to separate things there. What is the responsibility of the health sector? What the responsibility of the other sectors? What can be done short term? What can be long term? But can we do a lot? Yes, we can. Should we start now? Yes, we should. That is also true. So thank you so much, everyone who has attended and participated in these 2 hours. If you're interested in our work on this part of COPD and our initiative of our research on respiratory health, you can contact us, and that's it. Thank you. Thank you so much for your words, esteemed Dr. Bodi, and I give the floor now to Dr. Maria del Carmen Calle to give us her final closing words in this webinar on behalf of this association with the World Health Organization. Thank you so much. First of all, I want to thank everyone for the participation of all the speakers from the different points of view. You have talked about something that is something that concerns us all, and that is not on anyone's political agenda. At least in Latin America and the Andean region, it isn't. I worked with the first lady, I lost count of maybe 15 years ago, bringing improved kitchens to stoves to the poorest regions of our country. So I know what we're talking about, and not just from the medical, clinical point of view, but from the social point of view. This is an issue that should be on the agenda, and we have to make it happen. But one thing is a political agenda, another thing is a public agenda. And of course, the WHO has to help us. It's already doing so. Dr. Castro is our special envoy, and he's working on that, is working with Dr. Tedros, and I think that's super important. Remember that we have a bunch of different situations, but anyway, this is going to elevate it a little bit more. So from the point of view of the WHO, the COPD is part of the NCDs, but we have to promote it to a higher level anyway. And the Andean Health Organ, well, this is a bit easier. There's 6 countries here, and I do think it's pertinent to start and have a work group to begin and to think of some kind of policy, something specific connected to respiratory health and with emphasis on COPD. I think from the Andean Health Organ, we can propose this, we can do this, and I also think that those of the people who have heard us and or who are going to listen to the recording tomorrow, what we've discovered is that on the next day, there are more reproductions of the webinar than the number of people who were actually logged in live. So we definitely have to post it. It's the fact that it has to do with prevention and treatment. So the issue of something that is always repeated in the Andean Health Organ is we have to accomplish dignity of life for the patients, right? There are no doubts, and our two pillars are make sure that everyone, without any difference, have access to the highest level of health and contribute to the decrease of inequality. That's what we have to do as an Andean organ. Why? For the increase of people's well-being and welfare. So when we're talking about prevention, we're talking about smoking. Of course, we cannot avoid that, and there are already policies that have already been very well stated. Well, there are many policies, but sometimes they don't get implemented. But in these 6 countries, we have very well implemented policies, and that they're pretty well handled as well. I'm not going to say that they're well handled in everything, but in its majority. And the second problem is pollution, and that's where everything that Laura and Anderson Boji said comes in. Is we're talking about clean air. We're talking about many things, really. We are talking about the Ministry of Transportation, right? A bunch of things. Pollution outside, inside, improved kitchens, biomass. There are several things. But something that I think we should not forget is the comorbidities that are going to make this worse. So what do we have there? Well, we have TB. We have chronic respiratory infection. We have pneumonia. It's all connected. I'm not saying that all of this causes COPD. Don't misinterpret me, but it makes things worse for sure. So we cannot forget the vulnerable populations. What does that mean? We cannot stop vaccinating. Against what? Well, tuberculosis, TBSG. We cannot stop vaccinating against influenza, against the pneumococcus, which at no point was mentioned, but I remind you that that also has to do with the matter. And another important thing is I will put this into prevention because it's basically like a secondary prevention, because remember we have primary, secondary, tertiary prevention. Everybody remembers what the first one was, and they think the secondary and the tertiary don't exist. But what does that have to do with the precocious diagnosis? So I have a person who has certain symptoms. I'm not going to wait for them to get complicated. I need to diagnose, and that is part of the policies. In the policies, you can add improved services, incorporate this in the first level, incorporate certain algorithms, certain tools, some spirometers to make a precocious diagnostic. Because if you do that, then you take better care of your patients, right? You diagnose and then you treat. And another issue is treatment. And there, treatment, obviously, medication, we have bronchodilators, we have steroids, and that's where universal access comes in. Because not everyone can buy these things, but well, I mean, a bronchodilator is something that's quite special, right? It's much more expensive. So there's a whole issue there. And what can we do there? We can talk to make sure that they are incorporated into the petitionaries, because sometimes they're not incorporated into the national petitionaries. This is something that can be done with single line also. And another important thing is to have access as part of the insurance, public insurance, which we have in our countries, to get more access. So that's what we're looking at. But another issue is oxygen therapy, which is, well, like the total crisis that we suffered when COVID happened. People were asking me, how do we help? Because when I was at a rotating doctor, and they were saying, we don't have oxygen tanks. And doctors from other countries were saying, seriously, you're still using oxygen tanks? No, oxygen is embedded. And then that left me thinking. We have many gaps in many things, but oxygen is important because there are going to be people who will need oxygen. And with people with our COPD patients, they're living more now. You live with COPD and the years go on, the years are increasing, and at some point they're going to be oxygen dependent, of course. The other issues, everything else, and here I don't remember who mentioned it, everything that has to do with, well, we cannot just prevent, see, we also have to rehabilitate in respiratory wise. We have to provide palliative care. It's a whole spectrum. It's not just over here. And I think that with great pleasure, I can say that we can think about this, that we can propose this at a ministry meeting. It's worth thinking about, because what we have done in the Andean organ is open the non-contagious illnesses a bit, so not put everything into the same bucket, because then it kind of gets lost. They're part of the political agenda. That's the thing that gets promoted the most. So what would we have done? We have promoted the policies on overweight and obesity, on pulmonary chronic illnesses, and cancer policies, including child cancer, not as part of a one big bag, but separately. So we could talk about respiratory health with emphasis on COPD. Now, something that for us is really important in the region is asthma. Asthma is super important for us in the region. The percentages of children with asthma are really high. In Peru, we are talking about 15, 18% with the weather that we have. And we have good weather, but you know, in Peru, basically we are breathing water. The humidity is ungodly. So thank you so much. It's been a great webinar. We have received a lot of information, but the most important thing is that we leave here with a commitment of continuing to work on this issue. We know Laura now, so we're going to talk to her to see what else can we do in favor of making sure that this illness, this disease is put on the agenda, and those who suffer from it actually have access to better quality of life, and so that we can prevent having further complications with it. Thank you so much for your time. We await your presence on Tuesday 26 at 5 p.m. We will be talking about premature infants, because as you know, on the 17th, September 17th, was the day of premature birth. So we're going to be talking about premature pediatric care strategies and impact, things that have yielded results. And as Bodhi said, we have to make things scalable, right? Because sometimes they stay at one place and we have to scale them up into something massive. So thank you so much, Anders, Laura. Thank you, Dr. Tonya, Sara. Thank you so much, Boji. Thank you, Stephanie, and the entire group of the Andean organ of health, and everyone who has made this webinar a success. We'll see you soon. Thank you so much. Bye-bye.
Y a nuestra intérprete también.
And our interpreter as well.
Elena es fantástica.